Hello friends, welcome back to Pharmacology Made Simple. In today's class, we will discuss about the anticholinergic drugs. Anticholinergic drugs are agents which block the effects of acetylcholine on cholinergic receptors, but conventionally antimuscarinic drugs are referred to as anticholinergic drugs. They are also called cholinergic blocking or parasympatholytic drugs. Drugs that block the nicotinic receptors are ganglion blockers and neuromuscular blockers. Anticholinergic drugs include atropine and related drugs. That is, atropine is the prototype. The classification of anticholinergic drugs. They are classified as natural alkaloids, that is, atropine and hycosine, and semi-synthetic derivatives, that is, homoatropine, ipratropium bromide, titropium bromide. The synthetic substitutes are mydriatics, that is, eucatrophine, cyclopentolate, tropicamide, and the antispasmodic are anti-secretory agents such as propylene, dicomine, oxyphenone, glycopyrrolate, telizepine, tolteronide, and propyrivine. The anti-Parkinsonian agents are benzhexol, benztropine, and trihexyphenidyl. Next, we move on to the actions of atropine. The actions of atropine and scopolamine are similar, except that atropine is a CNS stimulant, whereas scopolamine is a CNS depressant. On the cardiovascular system, atropine increases the heart rate. In large doses, vasodilation and hypotension occurs. So here we can see that atropine will increase the heart rate, whereas it will decrease the blood pressure. On the secretions, atropine reduces all secretions except milk. Lacrimal, salivary, nasopharyngeal, tracheobronchial, and gastric secretions are decreased. Decreased salivation results in dry mouth and difficulty in swallowing. It is an antisiolog. Sweating is also reduced. Therefore, it reduces all the secretions. On the smooth muscles on the gastrointestinal tract, it decreases the tone and motility and relieves spasm and may result in constipation. Whereas on the biliary tract, the smooth muscles are relaxed, biliary spasm is relieved. On the bronchi, atropine causes the bronchodilation. And on the urinary bladder, it relaxes the ureter and urinary bladder and may cause urinary retention, particularly in the elderly men because they may be having prostatic hypertrophy. So on the smooth muscles, generally it will decrease the tone, motility, and causes the relaxation. On the eye, on local installation, atropine produces mydriasis by blocking the muscarinic receptors in the sphincter pupillae. The ciliary muscles is paralyzed, resulting in cycloplegia or paralysis of accommodation. Because of mydriasis, the iris may block the drainage of aqueous humor. Intraocular pressure increases and may precipitate glaucoma in some patients. Okay, so what happens in the eye? The intraocular pressure will increase because of the blocking of the muscarinic receptors. On the central nervous system, in higher doses, atropine stimulates the central nervous system, resulting in restlessness, disorientation, hallucinations, and delirium. In contrast, scopolamine produces sedation and drowsiness. Here we can see the difference between the sympathetic drugs and the parasympathetic. drugs, it is just the opposite of each other. In the sympathetic drugs, it will dilate the pupil, inhibit the salivation, it will cause the bronchial dilation, inhibit digestion, stimulate glucose release by liver, stimulates epinephrine and norepinephrine release, relaxes bladder, contracts rectum, and it causes the orgasm or ejaculation. Whereas the parasympathetic drugs, it constricts the pupils, stimulates the salivation, decreases the heart rate, and causes the bronchial constriction, stimulates digestion, stimulates gallbladder, contracts bladder, relaxes rectum, and vaginal lubrication and erection may occur. The pharmacokinetics of atropine are atropine and hycosin are well absorbed. It crosses the blood-brain barrier and are metabolized in the liver. The adverse effects are common but not serious and include blurring of vision, dry mouth, dysphagia, dry skin, fever, constipation, and urinary retention. Skin rashes may appear. High doses cause palpitation, flushing, restlessness, delirium, hallucination, psychosis, convulsions, and coma. Poisoning is treated with IV physostigmine. The side effects of anticholinergic drugs are: in the eyes, it causes the blurred vision or dry eyes. On the brain, it causes the drowsiness, dizziness, confusion, and hallucinations. On the mouth, it causes the dry mouth. In the bowel, it may cause the constipation. On the skin, it may cause the flushing and unable to sweat and overheating. On the bladder, it might cause the urine retention, unable to empty the bladder. On the heart, it will cause the rapid heart rate. Next, we move on to uses of Belladona alkaloids. The uses of Belladona alkaloids as antispasmodic are: in diarrhea and dysentery, atropine relieves the colic and abdominal pain. In renal and biliary colic, atropine is used with morphine because atropine partly overcomes spasm of the sphincter of Oddi. And nocturnal enuresis, that is the bedwetting in children, and in paraplegia, atropine reduces the urinary frequency. As mydriatic and cycloplegic, it is used in the diagnosis for testing of error of refraction and fundoscopic examination of the eye. And the therapeutic use is to provide rest to the iris in iritis, iridocyclitis, keratitis, and alter partial iridectomy. As a pre-anesthetic medication, when administered 30 minutes before anesthesia, atropine reduces salivary and respiratory secretions. This will prevent the development of laryngospasm. It also prevents bradycardia during the surgery. Its bronchodilator action is of additional value. Glycopyrrolate, an atropine substitute, is most commonly used for this purpose. And in case of organophosphorus poisoning, atropine is a life-saving drug which is used in organophosphorus poisoning and is also useful in mushroom poisoning. In case of bronchial asthma, peptic ulcer, and Parkinsonism, atropine derivatives are preferred over atropine. In case of motion sickness, hycosin given 30 minutes before the journey prevents the traveling sickness. Transdermal hycosin patches are available to be applied behind the ear for a prolonged action. And hycosin can also be used during labor to produce the sedation and amnesia. That is about the uses of Belladona alkaloids. The drug interactions are when anticholinergics are given with other drugs that also have anticholinergic property like antihistamines, phenothiazines, tricyclic antidepressants, the side effects get added up. Next, we move on to anticholinesterases. Anticholinesterases are either esters of carbamic acid, carbamates, or phosphorus compounds. They may be reversible, that is physostigmine, neostigmine, donepezil, edrophonium, whereas the reversible ones are organophosphates, that is ikethiophate, malathion, sumethion, and toxic nerve gases such as sarin and tabun. The carbamates are carbyl, propoxia, and adicarb. Physostigmine is an alkaloid obtained from the plant Physostigmina venenosum. It is a tertiary ammonium compound, hence has better penetration into tissues and can also cross the blood-brain barrier. It is available as IV injection as 0.1 to 1% eye drops and in combination with pilocarpine nitrate as 2%. It is used in glaucoma and in atropine poisoning. Its uses as eye drops can cause the brow ache and on long-term use, retinal detachment and cataract. Neostigmine is an synthetic quaternary ammonium compound and it is poorly absorbed in the gut. It does not cross the blood-brain barrier. It is used in myasthenia gravis and postoperative paralytic ileus and atony of the urinary bladder. Whereas the edrophonium is a rapid and short-acting, it is used in myasthenia gravis and intravenously in snakebite and curare poisoning. What is the difference between the physostigmine and neostigmine? Physostigmine is from the natural source, whereas neostigmine is a synthetic source. Physostigmine is a tertiary amine, whereas neostigmine is a quaternary amine. Physostigmine has good oral absorption, whereas neostigmine has poor oral absorption. And physostigmine has good tissue penetration, whereas the neostigmine has poor tissue penetration. The physostigmine causes the blood-brain barrier and CNS effects will occur, whereas the neostigmine does not cross the blood-brain barrier and no CNS effects occur. The main indication for physostigmine is glaucoma, whereas for neostigmine, it is myasthenia gravis. And it is used in, physostigmine is used in atropine poisoning, whereas neostigmine is used in curare poisoning. So these are the differences between physostigmine and neostigmine. Next, we see the uses of reversible anticholinesterases. As a mycotic, physostigmine causes meiosis, spasm of accommodation, and an increase in the intraocular pressure. It is used in glaucoma and can be used with pilocarpine for better effect, alternatively with the mydriatic to break adhesions between the iris and the lens. In myasthenia gravis, first of all, let's see what is myasthenia gravis. It is a chronic autoimmune disease characterized by progressive weakness with rapid and easily fatigability of the skeletal muscles. So what is myasthenia gravis? It is an autoimmune disease. And what is the characteristic features? That is progressive weakness, rapid and easily fatigability of the skeletal muscles. Antibodies to the nicotinic receptors are formed, resulting in a decrease in the number of these receptors at the neuromuscular junction. Neostigmine or pyridostigmine or a combination of these may be given. Edrophonium is used for IV for the diagnosis. In addition to its anticholinergic activity, neostigmine directly stimulates the nicotinic receptors and increases the amount of acetylcholine released during each nerve impulse. Anticholinergics enhance anticholinergic levels at neuromuscular junction by preventing its destruction. They thus increase the force of contraction and improve muscle power by more frequent activation of the existing nicotinic receptors. In advanced disease, anticholinergics are not effective because the available nicotinic receptors are very few. In poisoning due to anticholinergic drugs, physostigmine is used in atropine poisoning and in toxicity due to other drugs with anticholinergic activity like phenothiazines, tricyclic antidepressants, and antihistamines. Because physostigmine causes the blood-brain barrier, it reverses all of the symptoms of atropine poisoning, including the CNS effects. So physostigmine is a very good drug which can be used in case of atropine poisoning. Curare poisoning, skeletal muscle paralysis caused by curare can be antagonized by anticholinergic esterases. Though idrophonium has a fast action, it has less effective than neostigmine. Post-operative paralytic ileus and urinary retention, neostigmine may be useful. In case of cobra bite, cobra venom, a neurotoxin, causes skeletal muscle paralysis. Specific treatment is antivenom. Intravenous idrophonium prevents respiratory paralysis. In case of Alzheimer's disease, to overcome the deficient cholinergic neurotransmission, rivastigmine and donepezil are tried in this disease, but tracane is not preferred because it causes the hepatotoxicity. Coming to the actions of irreversible anticholinesterases, organophosphorus compounds are powerful inhibitors of anticholinesterase enzyme. Binding with the enzyme is stable by covalent bonds. They bind only on the esteratic side and the enzyme is phosphorylated. Effects are similar to that of cholinergic stimulation as acetylcholine accumulates in the tissues. Organophosphates are highly lipid soluble and hence are absorbed from the roots, including intact skin. This makes organophosphorus poisoning possible when insecticides are used for spraying. The uses of irreversible anticholinesterases are glaucoma. Ectopioid eye drops are sometimes used in glaucoma. Next, we see what is organophosphorus poisoning. As organophosphates are used as agricultural and domestic insecticides, poisoning by them is quite common. Poisoning may be occupational as while spraying insecticides, accidental or suicidal. Symptoms result from muscarinic, nicotinic, and central effects. The symptoms are vomiting, abdominal cramps, diarrhea, meiosis, sweating, increased salivation, tracheobronchial and gastric secretions, and bronchospasm, hypotension, muscular twitching, weakness, convulsions, and coma. Death is most commonly due to the respiratory paralysis. What is the treatment of organophosphorus poisoning? If poisoning is through the skin, remove the clothing and wash the skin with soap and water. If consumed by oral route, gastric lavage is given. Maintain the blood pressure and patent airway. The drug of choice is Atropine 2 mg every 10 minutes till pupil dilates. The maximum dose can be anything from 50 to 100 mg or more depending on the severity of the poisoning. Treatment should be carefully monitored because of the risk of reappearance of symptoms due to delayed absorption of organophosphorus compounds. The cholinesterase reactivators such as paralidoxamine, obexamine, these oxime compounds combine with the cholinesterase organophosphate complex and they release the binding and set free the anticholinesterase enzyme. Thus, they reactivate the cholinesterase enzyme. They should be given within minutes after poisoning, preferably immediately because the complex undergoes aging and the enzyme cannot be released. The complex becomes more stable by loss of a chemical group and this is responsible for the aging. Cholinesterases are not useful in poisoning due to the carbamate compounds because these compounds do not have a free site for the binding of oximes. Moreover, paralidoxamide itself has a weak anticholinesterase activity, particularly at higher doses. In severe poisoning, 1 to 2 grams of IV paralidoxamide given within 5 minutes of poisoning gives the best result. But in practice, it is rather uncommon for a patient to get such quick treatment within minutes, particularly in the rural setup, and cholinesterase reactivators are tried up to few hours, the maximum of 24 hours after the poisoning. Here you can see how the organophosphates bind to cholinesterases, preventing the breakdown of acetylcholine. So therefore, the symptoms of the organophosphate poisoning on the nicotinic receptors with the mnemonic is dumbbell bells, that is diarrhea, urination, meiosis, bradycardia, bronchospasm, emesis, lacrimation, lethargy, salivation, and seizures. Whereas on the muscarinic receptors, the mnemonic is sludge, that is salivation, lacrimation, urination, diarrhea, GI cramps, and emesis. The treatment is atropine, titrate dose to drying of bronchial secretions, and ferrolidoxamine helps to regenerate the cholinesterase. The important questions in these topics are: first, classify the anticholinergics and write the pharmacology of atropine, that is asked for 10 marks. Next, classify anticholinesterases and differentiate between physostigmine and neostigmine, that is asked for 10 marks. Next is organophosphorus poisoning and its treatment, which is asked for 5 marks. Uses of atropine for 2 marks. Name 2 reversible and 2 irreversible anticholinesterases, that is for 2 marks. Hope you understood thoroughly about this topic. Thank you, students. Please do like, share, and subscribe.